Wombell. I'm the Senior Clinical Nurse Specialist for the Chronic Pain Services here at BHRUT Hospitals. Just going to try and bring up the slideshow. There we go. So I've been asked today to do a presentation on opioids. It's a little bit of background history about myself. I've been nursing for 25 years now. Initially started obviously on the wards, worked on various different wards, mainly on a respiratory ward. And then I got into chronic pain. Well, initially got into acute pain and worked with the acute pain service, helping patients, post-surgical procedures, patients that come in with injuries, etc. And obviously during the last 5 years, I've set up an opioid reduction service, mainly for patients that have been referred either indirectly from GPs that are on high dose opioids, or that we've picked up when we've been assessing them for other conditions that they've been referred to us for. So, as you probably all know, opioids are a class drug that are potent analgesics, and obviously they are potentially dangerous. They are used widely in treatment for acute pain, cancer pain, and chronic non-cancer pain. However, there is growing controversy about their use and whether they should actually be used for treating chronic non-cancer pain. So that's the patients that I see with chronic conditions. The most commonly drugs that I see within my opioid reduction clinic over the last 3 years, roughly about the same amount, fentanyl and morphine tend to be the most commonly prescribed drugs I see. Numbers, that's a completely separate thing that I look at. So opioids provide moderate quality pain relief, and evidence shows this is now not sustained long-term with chronic pain. And ideally, they should only be used for short-term and are more effective in the use of acute pain or cancer pain. And just an example here of this cocodamol box, again, identifying that ideally it should be used for 3 days only, yet many of the patients that I see have been on cocodamol for anything up to 10 years. And obviously they're still in pain, they're still suffering, and they have quite a poor quality of life. So using opioids, why did we start using opioids initially? Well, about 20 years ago, opioids were used as a treatment for chronic pain. And it was thought that if they worked well at first, that they would continue to work long-term if the doses were increased. And what used to happen, the patient would be given a low dose of opioid, it would reduce their pain, they would go back to the GP would say, oh, how did that medication help? Yeah, it reduced my pain. Okay, let's increase the dose. Again, it would help with their pain short term. They would go back to the GP, the drug would be increased. And that happens over several months, several years. And this is what has led to the fact that many patients I now see are on extremely high dose of opioids, yet they're still experiencing chronic pain. Many practitioners routinely prescribe opioids for chronic pain because they believe it's unethical to withhold analgesia, regardless of the etiology of pain. One of the things we try to educate within our service and within the trust is that we shouldn't just be actually assessing the pain of the patient, we should also look at their overall function. So for example, have they got improved mobility? Have they got improved sleep? Has their mental health improved? So we're actually assessing more than just one thing when we're looking at chronic pain in relation to opioids. There are quite a few side effects when it comes to using opioids. Obviously, the top ones, the most common, developing tolerance to the drug. So as I mentioned earlier, the patients require higher and higher and higher doses to get the same effect. Obviously, we all know that there is a risk of addiction. It can reduce and cause problems with the immune system. So it can make patients more prone to coughs, colds, flus, things like that. It can change their hormone levels. So it can reduce their bone density, it can reduce their muscle strength. And again, if they've already got a chronic pain condition, they're not moving around enough due to fear of movement, this can add to that symptom. Gastrointestinal disturbances, so again, most commonly constipation and nausea. It can also cause sleepiness or sleep disturbances. So again, if the patient has already got sleep problems due to their pain, it's found that the opioid will actually just exacerbate this problem. Another side effect can be weight gain or weight loss. low mood. And again, if the patient already suffers with low mood or anxiety, this can exacerbate that problem. Some patients do experience sweating. Some patients loss of sex drive, infertility, irregular periods, and poor concentration and memory. And again, a lot of my elderly patients have actually had misdiagnosis of poor cognition due to being on high doses of opioids. And the big one that everyone doesn't always realise is it can actually worsen the experience of pain. So it can actually, over time, the opioid will change the pain receptors and make patients feel pain at a lower level. So as I've said, it actually makes them feel and worsens their experience of their pain. So we know that opioids do not cure pain. And if a patient is taking opioids and they are still in pain, obviously not working, and the drug should be tapered down and stopped. And if you start to notice that the patient is getting less pain relief, this usually means that their body has become tolerant, needs to be tapered down and stopped. I will talk about this in the next couple of slides. The reason I mentioned taper down, reducing it, is hopefully we're all aware that opioids should never suddenly be stopped. It can cause quite severe problems and patients going to quite severe withdrawal symptoms. So it is something that should be reduced and a clear reduction plan set with the patient. So there are many opioid risks that's in the news. Obviously, we know about the risks in America, but some of these risks are now moving across to the UK. The Guardian was looking at unnecessary painkillers leaving thousands addicted. So again, patients through no fault of their own are starting to become addicted to these painkillers, which can make it very difficult to wean them off and reduce them. Unfortunately, in this part of the borough, if a patient is on a prescribed medication, they will not be seen by the Alcohol and Drug Abuse Centre. So again, it's something that either yourselves, the GPs, or I have to work with the patient to try and reduce it. Accidental addiction, again, as I've just mentioned, patients through no fault of their own are becoming addicted to the drug. Overdoses on opioid painkillers are starting to double in the last decade. Quite a few different reasons for that. One is the lack of understanding of the opioid. The patient thinks, well, if I take a couple more, it will help with my pain. Again, drugs like oxycodone, fentanyl, can be quite a big conversion rate when you put it to the equivalent of morphine in 24 hours. So again, it can cause respiratory problems. We often find that chronic pain runs in families. And I've often had patients in my previous role in acute pain admitted with respiratory overload or respiratory cardiac arrests due to the fact they took their mother's or their father's or their daughter's painkiller by mistake. Or intentionally to try and again get a higher dose of opioid. And as I said, this can cause quite severe problems with the respiratory. So in the last 10 years, opioid prescription rates have doubled from 12 million to 24 million. I am hoping that in the next 10 years, we will start to see a decline in that, particularly as we now trying to educate more about a self-management approach and more exercise and rehabilitation programs becoming available for patients. Admissions to hospitals for opioid overdoses have also doubled. And I mentioned about the lack of understanding with patients and how they can overdose on opioids, either, as I said, taking them themselves or using a relative's or a friend's drug. Obviously, because of these rates, deaths in England and Wales are also starting to rise. Interestingly enough, deaths for tramadol actually fell by 12% in 2015 to 2016. And one of the reasons we think this may have happened is because, particularly in this area, tramadol became a controlled drug. So it was no longer used as a backup for when patients were being discharged from surgery. Whereas now we tend to use cocodamol when patients discharged for surgery. So that could be one of the reasons, and the fact that tramadol wasn't being prescribed as frequently in the hospital, and then patients weren't being discharged on it, and therefore subsequently repeat prescriptions weren't being written for it. More opioids were prescribed in the north than in the south. And again, this is usually due to the fact that areas in the north do have greater social deprivation. And because of this, the next slide obviously shows that if there's more drugs being prescribed in the north, that obviously the deaths of opioids are going to be high in the north. I often show this quote to a lot of my patients when I'm talking to them about opioids and opioid reduction, because I find it quite an interesting quote from a gentleman called Thomas Willis, who was a doctor back in the 1800s. And he even recognized back then that the angelic face of opium is a dazzlingly seductive drug. But on the other side, it will appear altogether a devil. There is so much poison in this all-healing medicine that we ought not to by any means secure or confident in the frequent and familiar use of it. So even back in the 1800s, yes, he knew it was a useful drug, but he recognized that it was quite a dangerous drug and that we should be very careful in how we use it. Yet, as I've just shown you those previous statistics, we don't seem to be understanding the high risks of opioids. So many of you may be aware of the International Association for the Study of Pain, and back in 2018, they released a statement on opioids. And obviously, they talked about them being indispensable for the treatment of short-lived pain, so acute pain, particularly as I've mentioned, surgery or short-term injury. But they do recommend that extreme caution should be used when prescribing opioids for chronic pain. And it goes on in a lot more detail, again, to talk about measuring not just pain, but measuring function, and if the patient's function improves if you are using opioids. So the British Pain Society talk about risk of harm in relation to opioids, and they say the risk of harm increases substantially for patients that are using oral morphine above the dose of 120 milligrams a day. I personally still think that's too high. So I don't tend to talk to my patients about this. If they're on any sort of dose that I feel is causing them additional side effects or causing them additional pain, I will try and reduce it. But this can be quite a useful statement to use if I have got patients that are on quite high doses. And obviously, if they are on high doses, again, reducing or stopping these medications, it does need very careful planning and collaboration with the patient. So how do we go about reducing opioids? When I'm working with my patients, one of the first things I do with them is explain to them what an opioid is and that the function of it is ideally to be used for acute pain only. I will highlight the risks and the side effects of the patient. So I'll often bring up that slide that I showed you earlier, and often try and make them understand that a lot of the symptoms that they're actually experiencing are probably going to be exacerbated by the high use of opioid. I will also try and explain to the patient the fact that they've in the pain clinic, they're still in pain, they're on high doses of opioids, and it's not actually improving their function in any way. I will then often work with the patient to set a plan to try and help reduce it. And I will always do this in a slow, controlled manner. And I will then do regular patient updates depending on the reduction plan. Now, I would say the majority of my patients, it is normally a monthly reduction. I've had one or two during lockdown that did want to do it weekly, but that's very, very rare. It normally is a monthly reduction plan. Sometimes I will have to hold the wean. So the patient may be struggling at a particular dose, experiencing withdrawal symptoms. It is okay to stop for a couple of months, allow the patient to get sort of used to that dose, and then start again a couple of months later. Again, I always explain to the patients, it's not a quick fix. It's not going to happen in a few months. Some of our patients, it has taken a year or 2 years to get them off this medication. But doing it that slowly, they do have less side effects and they do have less withdrawal symptoms, and they do then start to see an improvement in their function. They're very aware that their pain hasn't changed, but they often do see a definite improvement in their overall function. So how did I start finding out how to reduce opioids? Well, help, support, advice and guidance. There is very little information out there. I did my prescribing course. That was not very helpful in how to reduce opioids. So over the past few years, and when I first started the role, I literally just Googled everything I could find on opioids. I did do a medication sort of update a couple of years ago, and I met a lady that worked in Somerset, one of the nurses, and she recommended this toolkit for tackling chronic opioid use in non-cancer pain. So I have put that in the chat box later if you want. There's quite a good it takes you to lots of other different websites that will advise you on how to reduce opioids safely. And also I met one of the nurses from Oxford University Hospitals, and they had a guidance for opioid reduction, which again, she said I could use and look at, and was happy for me to share it. And this is what they share out with their GPs, again, on how to reduce opioids safely and effectively. Within the service myself, I have filmed 2 presentations, one on opioid medication use and one on opioid medication reduction. I filmed this during, don't know what's happened there. I do apologise. That one will. Okay. As I was saying, I filmed this during lockdown, and I've started to send it out to patients that I am trying to wean off their opioids. I also have an accompanying leaflet that goes with this. So if the patients are not able to access YouTube, they can use the leaflet as well. And it just details the risks of opioids, what side effects it can cause, and some of the withdrawal symptoms if we do start reducing that they may experience. So that a lot of my patients have found that quite helpful. When we're talking about opioid alternatives, got a lot of patients, when I start taking them off opioids, well, what am I going to use instead? What are you going to replace it with? So again, it's trying to talk to them about their chronic pain condition, giving them some understanding about their condition. We often talk about endorphins within our service and the natural opioids in the body, and how these are actually between 18 and 33 times more powerful than chemical opioids. I try and encourage the patient to think of ways they can provoke the endorphins artificially. Obviously, with yourselves in the GP surgeries, you may want to think about social prescribing, encouraging the patient to go to the gym, swimming, any form of arts and crafts, encourage gentle walking. As I mentioned, self-management. And within our service, we also do offer patients pain management programs, which offers them a variety of techniques and strategies to help manage their pain on a day-to-day basis. As we always tell the patient, it's not a cure for their pain, but hopefully it will help them live with their pain rather than suffer with their pain, which most of the patients that refer to us are suffering, and we want them to be able to live with their pain. Also, you may be aware of the NICE guidance that recently came out this year. A lot of controversy around this guidance, but the main management they talk about in regards to chronic pain and primary and secondary pain is firstly that your management should be person-centered. We know that every single patient with a chronic pain condition is slightly different, and they're going to have different needs and different requirements. Give them as much advice and support as you can about a chronic pain condition. Again, helping them understand that if they're in pain, it doesn't necessarily mean that there's damage going on in their body. Be very careful with the language that you use, particularly for describing MRIs or reporting on MRIs with the patient. Things like degenerative disc disease can be quite frightening to the patient. The word disease means something terrible is going on, when actually degenerative disc disease is actually normal aging. And saying that to the patient, you know, you have normal aging of your back, is far more easy to accept than someone saying, you've got this going on, you've got disc disease. It can be quite frightening for that patient. NICE guidance management also talks about flare-ups. And again, during lockdown, I filmed a flare-up presentation that's accessible on YouTube. And also I put together a leaflet to help patients, again, manage their flare-ups that they will experience. Exercise programs are another thing that's been mentioned in the NICE guidance. Again, psychological therapy is really, really important, having a history about the mental health of that patient, and particularly if there are some quite horrific things that may have happened to them previously or in their childhood. Again, that may need to be addressed before you can even look at their pain control. Acupuncture is now back on, has been recommended under the NICE guidance, but again, there are very, very strict regulations under this and about it being just a one-off course. And pharmacological management, talking about use now of just antidepressants, whether that's duloxetine or amitriptyline, and again, very close monitoring of the patient on this drug. Again, explaining to the patient why we use this medication, not because they're depressed, but we have found that in different doses, it can help with chronic pain. Also explained to the patient it's not a drug that will work instantly. So both duloxetine and amitriptyline can take up to 2 to 3 months before the patient notices any effects. And again, explain to them it's not a cure. If anything, they will probably only see about a 30% reduction. So again, as a service, we're always saying to patients, this will be used in conjunction with self-management or in conjunction with injections and self-management. So make them understand that one thing alone will not necessarily cure their pain. It's multifaceted. Obviously, things like pregabalin and gabapentin have now been taken off and advised not to be used for chronic pain. So I'm going to briefly talk to you now about a case study, quite a good success story, one of my patients. So this is a female 75-year-old lady that was initially referred to the service back in 2020 with back pain. She had polypharmacy on lots and lots of medications, but the two obviously that I picked up on that was she was on the interactions of diazepam and morphine. She was taking both morphine, MST, and liquid Oromorph, and in a total 24 hours, it was the equivalent of 190 milligrams of morphine. Sometimes more, sometimes slightly less, depending on how much liquid morphine she would use. She suffered with quite severe anxiety, lived in sheltered accommodation, very rarely engaged in any form of activity with the other residents, very, very supportive daughter, and to start with, the initial telephone consultations that I had with the patient wasn't actually with the patient, it was actually with the daughter. As I just mentioned, the first clinic I held in June 2020, the daughter had to assist because the patient, one, didn't really want to engage, and two, was asleep most of the time in the chair, the daughter was telling me. So we discussed the risk of opioids, and we agreed that we would reduce by 5 milligrams per month, and that I would follow her up every 4 weeks. Managing quite well for the first few months, but then in October, she started to develop withdrawal symptoms of hot flushes and heart palpitations. And because of her anxiety, this actually was exacerbated because she was getting quite worried whether this was a heart attack she was having or whether it was actually withdrawal symptoms. During this time, her daughter had looked into trying to find information about opioids on the internet for patients and found that there was a lack of this available and what to expect in regards to withdrawal symptoms. So what we did is we temporarily held the withdrawal and we stopped and we held it at 110 milligrams in 24 hours. I contacted her again in the new year and we then restarted the morphine reduction. She'd watched the video that I'd sent her on flare-up planning, and the daughter said she'd actually started to become a little bit more engaging. She had a tablet that she was sort of able to access and go onto the YouTube, which the daughter had never seen her use before. And one of the things I mentioned in my flare-up video is something called a flare-up box. And the daughter had explained to me that her mother had put together this flare-up box. And one of the things she put in it was some Lindt chocolates. So that if ever she was in a little bit of pain, she'd go over to a box and help herself to a little Lindt chocolate, and that would make her feel a little bit better. In July 2021, when I last spoke to her, we've now reduced her to 90 milligrams of morphine in 24 hours. We are continuing with the 5 milligrams per month withdrawal. I've spoken to both her now, and I very rarely need to speak to the daughter now because the patient can now actually carry out the conversation herself. She's less drowsy, her mobility has improved, her appetite is improved, and the daughter's told me she started going to different activities that are held within the centre that she stays at. Also, for the first time last week, she actually phoned me and the patient herself and thanked me for the help and the fact that she was starting to feel a lot better, and all the pain, although the pain was still present, as I've mentioned, overall her function was improving. I'm now doing 6 monthly follow-ups and I'm due to speak to her again in the new year, but she knows that if anything happens between that time, she can access and contact me at any point. So lessons learned from this case study. As I mentioned, the daughter spoke to me to tell me that there were absolutely no information on the internet or Google or anywhere for patients. There is some obviously for clinicians, but not a lot of information for patients. So this led me to develop a opioid leaflet, which I've mentioned earlier, which describes opioids and the risks, and again, what withdrawal symptoms the patient may experience. I also, as I've said, filmed 2 online presentations which are available. So again, if the patient does have access to YouTube, they can watch these videos and again, more information and more understanding about the risks of opioids. And again, sometimes my clinic sessions are quite short, and if I only get 20 minutes with the patient, it's a lot for the patient to take on board. So having these online presentations and leaflets means they can constantly access them as and when they need. So in summary, as I said, I've been running my nurse-led reduction service now for 4 years. And in that 4 years, I've seen 76 patients. I have had more referred, but there were a few that wouldn't engage. The median dose of the prescribed oral morphine is the equivalent of 180 milligrams 24 hours, which is quite a high amount. Over 3/4 of the patients referred to me were taking over 120 milligrams, which is the recommended dose by the British Pain Society. 35% of the patients referred to me, I've managed to completely stop their opioids. And 65% of the patients referred have been able to reduce their medications by half. Again, most of the patients' pain hasn't really changed, but overall their satisfaction, their mood, their cognition, and their well-being has improved when the opioids have either stopped or they've been reduced. And taking this information further, I've presented this information on our own Trust Safety Summit at a previous Havering GP Engagement Day. As I mentioned, I filmed the 2 online presentations and ongoing work over coming next year. We are hopefully going to have a psychologist join our service, and I'm hoping the patients that I cannot get to engage, she might be able to work with them and might help them understand furthermore the risks, so I can again get them on board with regards to the reduction. So quite long-winded, thank you for listening, and I will now let you open up the floor to any questions.
Can I just ask you, could you please send to GPs the opioids leaflets?
Yeah, so if Tima sends me, I can send it to her, then she can forward it on to you. So yeah, the leaflet that I use, which will be my own leaflet that I've prepared, I can send that to you if you want. Yeah. I'll make a note of that.
Afternoon all. So if you wanted any resources from Sarah, could you kindly please put in your first name, your last name, and your current email address so I can send it to you? Thank you. Are there any more questions for Sarah today?
I've got a question, please.
Yeah, go ahead.
Can a patient, just generally speaking, can a patient actually force your hand to prescribe them opioids? Of course, after you've tried your level best to convince them and give them alternatives and everything. I've had a couple of patients who are clearly just addicted, and you know, they start complaining or making a fuss, and I'd have to give up at the end. At the very end, is it, because you mentioned it's patient-centered, can they actually force your hand if you think they don't need it?
I will never, I mean, they can't force my hand because I won't prescribe an opioid for them. The only patients we ever, and it's very, very rarely we prescribe opioids, are ones that absolutely nothing has worked for. It's normally the ladies that, or gentlemen that are in their very, very sort of 90s, and we normally would do a very, very low dose of buprenorphine patch. But I will never prescribe an opioid for a patient. Patients that don't want to engage, again, I can only give them the information out there that I have available to them. They can make an informed decision if they don't wish to come off the opioids. Unfortunately, I cannot force them. You obviously, as a GP, you can have the access to hopefully try and bring them back into clinic 6 months later and go through the information again with them. But I would never increase an opioid and never prescribe an opioid. If, as I said, a patient is struggling with a reduction, I would tend to hold it and then we'll assess it every month, or we'll hold it for 2 or 3 months, and then we'll restart again. And that's normally the ones that are cooperative. But I always have patients in my service that don't want to cooperate, cannot understand why I cannot give them any other medication, cannot understand why I will not inject them. So again, it's just about sending out that information, allowing them to make an informed decision, and at some point in their life, they'll get to that point in the journey where they'll realise there isn't anything for their chronic pain condition. I noticed somebody mentioned in the chat box about elaborating on withdrawal symptoms and how best to manage. Withdrawal symptoms can vary in patients. I mean, the most common ones you tend to get are nausea, headaches. What I tend to say to patients is make sure they're well hydrated. If possible, I will sometimes ask the GP to prescribe an antiemetic for short term. But usually, because I'm doing it at such a slow rate and such a small dose, I don't often see huge withdrawal symptoms. Often you'll find the withdrawal symptoms sometimes are more around anxiety than an actual withdrawal symptoms. And then it's sometimes just providing them with that emotional support. Do they need a psychologist? Do they need talking therapies? It's looking at those things as well. But the most common, as I said, is normally nausea, sickness, and it will be making sure they're well hydrated, and if possible, short-term use of an antiemetic. I hope that answers that question. Miriam, have you got your hand up?
Yeah, thanks, Sarah. My question was that you have this service at Queen's. Do you have a criteria of what we can, which kind of patients we can refer you to?
So all referrals will go directly to our referral team. They will be graded by the consultant. So it will be like a normal referral you would do. And then, unfortunately, due to the way the service is set up, the patient always has to be seen by a consultant first. And then they will then come to me afterwards. We are looking at next year. We've already started trialing it with a joint clinic with physio and consultant together. And we're looking at trialing next year a joint clinic with myself, physio and consultant. So we kind of split patients. But it would be exactly the same as a normal referral you would do to our service, just stating that you need help or assistance with reduction in their opioids.
Sarah, could you also, with the email, with the leaflets, could you also have the YouTube link so we could have it in one email and we can?
Yeah, I assumed you would. I assumed you would want that. I was also, I'm assuming it would be helpful to send the toolkit as well that I initially started using when I first started. Because as I said, I didn't really know where to go or who to turn to. So
yeah, that would be great
that I found was quite helpful.
We could forward it to our other colleagues as well.
Yeah, so I was going to include that anyway, because I thought no doubt you would need that, because it is quite daunting, you know, when you first start, because like I said, there isn't a lot of help out there, unfortunately, and a lot of the advice, it will talk about things like a 10% reduction every week. Well, if you've got a patient, I mean, some of my patients I see on 900 milligrams of morphine in 24 hours, that 10% reduction is actually going to be quite a large amount. And I think that'll be far too quick for the patient. So again, I tend to just work with the patient, see what they want to do, and as I take it either every 4 weeks or sometimes every 2 months. But it's working extremely slowly with that patient. And it was only during lockdown I said about 2 patients that said, right, we're in lockdown, I'm not going out, I want to do it, I want to get it over weekly. And they literally shot down and didn't have any side effects, strangely enough, or withdrawal symptoms, and coped quite well. But that was, again, a one-off situation because they weren't going out or seeing anybody.
Just a follow-on question, Sarah. You know, there are some patients who are on Oromorph as well, the regular opioids, and you know, you get a few patients who will be constantly calling you every 2 to 3 weeks. Their Oromorph has run out, they'll be crying that their pain is not being controlled. Now, how do we handle these patients? Because of course, if they're crying, like it's quite hard, because you know, you'd feel kind of like obligated if they're using more than they need to as well. So would you increase their morphine, the tablets, or would you just not do anything?
No, again, if they're already on a reduction plan, the idea is to try and encourage them not to increase the use of Oromorph. And again, I don't Normally, my patients are quite good and they don't increase the use of oral morph. Or you can decrease the oral morph first. So actually do a reduction plan with that. There's no set. So if you've got a regular medication and a PRN medication, there's no rule as to which you reduce first. So when I'm assessing the patient, if I've got a patient that's using the oral morph 6 or 7 times a day, I'll actually work on that first, because that is the more of the addictive thing, that's more the problem. So I'll actually sometimes work on reducing the PRN medication first, get rid of that, then you can slowly start working on the regular medication. Again, every patient is individual, but you'll find that when you're doing that assessment, if they're frequently using the liquid morphine, it might be better to start the reduction of that first rather than the twice a day medication. Does that answer your question, Miran?
Are there any more questions for Sarah?
I was going to ask you, I think we should not give a morphine to the chronic backache patients in the long term anyway. I don't know how these patients you mentioned, they're taking such a high dose for so long.
So what was it about? Why are they on such high doses?
Yeah.
Yeah, I mean, often it's because unfortunately it is that some GPs will continue to prescribe and prescribe and prescribe. And obviously that's where the problem lies, in the sense that the patient thinks the GP is helping them because they are increasing the medication. They come and see me and I become the bad ogre that's trying to get them off the medication. So that's usually why, unfortunately, it's this lack of understanding. And it's across the board. It's, you know, all different areas. I find that, as I said, unfortunately, patients have gone back to the GP, they've increased it. I've had one patient that I managed to finally get him on board. He was on 900 milligrams of all different types of opioids, but it came to the equivalent of 900 milligrams in 24 hours. And I'd finally got him on board to start decreasing his medication, slowly started doing it. And then he had a little bit of increase in pain. It went off to the GP increased the morphine, and that was it. I lost all confidence with him, and there was no way I was going to reduce it because he thought the GP was doing the right thing. So I couldn't engage with him anymore. And as I said, unfortunately, we had to discharge him because that was it. I'd lost that confidence with, he'd lost that confidence with me because he felt that I was the bad person trying to get him off something and not giving him anything to replace it. And that's I always say that's the hardest thing I come across. Patients still have this idea in their mind that medications are going to cure them of their pain. And that's what I try and talk about every single meeting with them. It's not going to cure you. It's not going to cure you. You're still in pain. You can't walk up the stairs. You can't wash yourself. How is this drug helping you? So it's, again, trying to get that across. But that will always be my biggest barrier with patients, that they are determined they need a drug to cure them. Any other questions?
Yeah, I tell you a story. I've got a patient, she's 94. And she has got a polymyalgia rheumatica. And I think because she has been on steroids for a long time, I think she's getting the fractured vertebra with the pain. And I think the rheumatologists, I don't know, they start with the morphine patches and the oral morphine. I try to stop it, and I stop everything. But it's difficult. And she's on a morphine patches, sleeping most of the time in the chair.
That's quite common. That's quite common, unfortunately, with the and that's why I said that would be the only time we would introduce ourselves a buprenorphine patch, but we would recommend that we never go above 10 or 15. But if the patient is sleeping in the chair all the time, then is that really an effective, is that really a quality of life they want? So yeah, that is quite a difficult one to deal with, because you'll often find that some services will start an opioid, and then you're, I said, the one that's stuck trying to get them off it. I mean, what dose is she on?
I think prescribing, it's a 5 I think 5 or 10.
Yeah,
It's not a very high dose.
no, that's the dose we would
Yeah.
normally ourselves recommend if there was absolutely no other treatment that could be given to her.
No.
So normally
comfortable.
if it was us, yeah, we would exhaust absolutely everything else. We would exhaust. So, and I said, normally it's the elderly ones that can't always come to our pain management programs due to reduced mobility, needing ambulances, and because we run it off site, we can't do that. So that would be, in our case, the only reason we would start a very low dose, but we always make it clear in our clinic letters not to increase it above 10-15 micrograms.
Lovely, thank you.
Any other questions? You're more than welcome. I can see someone in the chat box has mentioned about pregabalin and gabapentin. One of the reasons, as far as I'm aware, they were taken off the NICE guidance as pregabalin and gabapentin started to become a street drug. So yes, they are just as addictive. Again, this was more of a northern problem it had become. So that was one of the reasons it was taken off. Also, there's not a lot of research for pregabalin and gabapentin in regards to long-term chronic pain conditions. I've been doing an audit myself on patients that I have referred to my clinic who I monitor on duloxetine, and I'm actually finding that out of the patients referred, only 30% get a response to the duloxetine, and again, it's only about a 20-30% reduction in pain, those that do respond. The rest either don't respond or they develop quite nasty side effects. So in our service, we tend to use duloxetine as the most common for widespread pain, fibromyalgia, those types of pains. But as I said, it is only a 30% response rate we're getting. And again, only a 20-30% reduction in their pain levels. So it's again, trying to encourage about the self-management approach alongside using medications. Someone's written about more information, sorry.
Sorry, I was going to say, gabapentin is used like a Smarties and is the most useless drug I've ever seen. I've never used it, but when they go to the neurologist, everybody prescribing expensive, useless drugs. They shouldn't have done that in the past, really.
Yeah. Someone's put into the chat box about duloxetine. So duloxetine, I would tend to, and this is just how I do it, depending if there's any form of depression or history, I always start them at 20 milligrams and build them up to a maximum dose of 60 milligrams over 3 months. If they have a history of depression or you're switching their antidepressant, I would normally go up to 90 milligrams. So that's tend to how I introduce duloxetine. But again, I do make sure I do careful. We do like a 3-monthly follow-up with the patients to make sure if they've responded, and partly as well because I'm collecting data on this. So as I've said, usually start fibromyalgia. So normally I start 20 milligrams and then each month I build up to a total of 60 milligrams. So 20, 40, 60 over a 3-month period. Making it very clear to the patient that it won't work instantly. It can sometimes take up to 3 months, and that sometimes that pain reduction is so subtle, they may not even always realize it's happened. It can be useful to tell your patients during the period of using medication to keep a pain diary, not necessarily to do it every day, but perhaps once a week. And then again, they can see over those 3 months, has their pain changed in any way? And I had one patient, again, it was such a subtle change, got her diary, she said, I didn't realise my toe pain stopped because again, she'd forgotten that her toes hurted. So it's quite useful to encourage patients, again, I said not to do it every day, but it can be done once a week or every couple of weeks. Any exclusion criteria to refer for your team? Only if they've got severe mental health issues. Obviously, you'd have to consider whether they would be more suitable for psychology support first before you refer them to us. But I don't have a maximum dose of analgesia. I mean, I've got a patient at the moment who's on quite a low dose, 20 milligrams of morphine twice a day. But she's asked herself to actually start coming off it, so I'm working with her. But there's no maximum dose. I've had as low as 20 up to as high as 900 I've had, so quite a range. But the only exclusion criteria would be ensuring they haven't got any severe mental health issues, because again, that's going to be something I would not be able to work with at the moment. I think my colleague, the chronic pain physiotherapist lead for the service, is going to be doing a talk in January or February time with behaving GPs about referrals and how to do them to our service. So that should be coming up in the new year. I haven't got the exact date yet, but he did tell me that he will be doing a session on that for you all. Just having a quick look, see if there's any more questions. Anyone got any more questions they'd like to ask me while I'm just looking through the chat box? Someone's mentioned about multiple opioids. Do you convert them all to morphine first? Tend not to convert. I'm very nervous about converting. So I will tend to work with one opioid first. Obviously with the conversion rates, and again, trying to find information where it all matches up. So I tend to, when I have patients on multiple opioids, I will work with just one opioid at a time. I think the most one I can think of, I had fentanyl, oxycodone, and Oromorph. So we worked on the fentanyl, which is always the hardest to get patients off of, mainly when you get to that very last 12 dose at the end. So sometimes I might temporarily add in some cocodamol as they're coming off the fentanyl. But multiple opioids, I don't like converting. I will always work with that opioid, but fentanyl is usually the hardest one because of the huge jumps you're getting between each dose. Any other questions?
There's one in the chat box for you.
Which one have I missed?
It's regarding your email.
Oh, my email address. Yeah, I can give you my email address. As long as you don't all bombard me, though.
Here's your perfect time to ask your last few questions before we log out.
And like I said, I will send you, well, I'll send them to Temi, the opioid leaflet, the YouTube links, and the toolkits. I'll also send you, so if any of you do want to ever use duloxetine, I send out the British Pain Society leaflets for that as well. And again, I said, make it very clear about the slow rates. So yeah, I'll send you out different leaflets that I use. Some are ones that I've produced, some are ones that the British Pain Society have produced.
That's fine then. I can only see around 21 emails in this chat. So if you have not put in your details, I will not be sending you any further information. I can only send people who've actually put in their details through this. So if you just want to put in the rest of your details, first name, last name, and your current email address, it can be your personal one or your email NHS one. Other than that, that's it all done. Thank you, Sarah.
Lovely. Thank you very much for having me.
Thank you. Well, we welcome. Thank you everyone else as well for joining the session today.
Thank you.
Please remember to put in your details or else I can't send any information. Thank you. Your feedback was, that was very helpful session. So they enjoyed it.
Good.
They enjoyed it.
Thank you.
So that's like doing evaluation.
Yeah. And I'm assuming what I'll do is I'll also send the slideshow as well. So if anybody wants anything of that as well, I'll send all that through to you as well.
That's the one I currently have.
Yeah.
Okay, no worries.
Thank you, Sarah. That was
Hi,
really helpful. We planned it for like 3 months, but we've executed it now.
I know. I know.
It was really helpful. I was just speaking to the CCG pharmacist. She couldn't get onto the link, but I'm going to send your information to her because she wanted to actually understand the service better.
Yep.
Because they feel that we need something bigger, or maybe, yeah. Oh, we're still recording. Oh, can we record?
Oh, let me stop that. Don't worry, I'll cut it out.
Yeah.